Hello my geniuses, welcome to another parasitology video. It's your great science tutor Lorenzo, and today we'll be talking about malaria. So because this topic is very sensitive and important, because especially to the African people where you have more breeding malarias around. So I'll be talking explicitly the medical part of it for students that is writing exams and easier ways to know it very well, even the different species of malaria. And also in another video we'll be talking about the pharmacology, which is drugs used to treat malaria, which we call anti-malaria medication. So stay with me to the end of this video because I'll be dissecting small different classes of malaria, how you see it, the pathogenicity, the complications, how to diagnose, how to treat, step by step. So you get it now. So stay with me to the end of this video, and because I'll be giving useful tips that you'll be needing for your exams. You get it now. So stay with me to the end and share it to all your classmates or people that need the video. Again, I'll show people that are about to write exams, so share it to them because it's more helpful. And also like, subscribe and share so we can make more content like this. So let's jump right into the video. So now the first thing we're introducing what malaria is. You get it now. So malaria is an acute chronic life or threatening protozoa disease. So note it, it's an acute and a chronic life-threatening protozoa disease, because when at sometimes when it is starting it could be acute, no, the symptoms are very minimal. Are you getting me now? It could be just be hiding in the body, it could be in a dominant form where it is not affecting you, it is asymptomatic. It could be chronic when it is causing complex symptoms to you. You get it now? So but one thing you have to know is an acute chronic life-threatening what protozoa disease. Why is it protozoa disease? Because it's coming from Plasmodium. So Plasmodium is a complex or protozoa species. You get it now? So it's a complex protozoa species. So malaria is an acute, chronic, life-threatening protozoa disease, which is characterized by fever. So fever, anytime there is a parasite or anytime there is a pathogen inside the body, what happens? The first sign is fever. So fever, splenomegaly, and you have other words systemic in manifestation. Okay, now so it's an acute or chronic life-threatening protozoa disease which is manifesting by what? Fever, anemia, splenomegaly, and what? Some systemic what? Manifestation. So what is the causative organism here? So what causes malaria here? So malaria is caused by what we call here is Plasmodium. Are you getting that? So Plasmodium is a causative organism that what causes malaria. So but we have different species of Plasmodium because Plasmodium is a genus. Yeah, so in the hierarchy of classification of organisms, so we have the kingdom, phylum, class, family, genus, species. So Plasmodium is a genus. Why? The female Anopheles mosquito is the one that transmits. So the mode of transmission of malaria is the female Anopheles mosquito, which means Plasmodium lives successfully in the female Anopheles mosquito. So I've introduced it and I'll give you the causative organism. So the next one we'll be talking about is different species of it. So always remember, malaria is an acute chronic complex protozoa disease. Are you getting now? So it's very life-threatening and can kill somebody. Are you getting now? And you can present it with fever, splenomegaly, and other systemic side effects. It could be complex, it could affect the brain. Are you getting now? So it's the mode of transmission is the female Anopheles mosquito, and the causative organism is Plasmodium. But we have different types of Plasmodium. We have the Plasmodium falciparum, we have Plasmodium vivax, we have Plasmodium malariae, and we have Plasmodium ovale. Are you getting me now? So these are different species of Plasmodium that can affect humans. So keep it very important. All of them are different. Are you getting me now? They are different in their morphology, their appearance, they are different in their immunology. Which is they differ in the type and degree of immunity they induce. When they enter into the body, they have different form in which they cause diseases to the body, and they are present in different localities. They are also different geological distribution, and their relapse pattern, which means who causes infection immediately, who waits first, or who keep themselves and relapse with time, and their responsiveness to drugs, they are also different. You get it now? And also the human impact here, which we'll be talking about here, the causes anemia. Why? Because they are affecting red blood cells. Splenomegaly, which means the liver tries to get rid of all those red blood cells. Are you getting me now? And it tends to be high increase, which means dead red blood cell back in the spleen causes splenomegaly. Hepatomegaly. Why? because the liver is trying much hard time to what detoxify this pathogenic product or antigen that they release in the liver. So the liver is working 2/7. So there will be hepatomegaly, and there's be always systemic side effect too we're talking about. Now the first one we'll be talking about is Plasmodium falciparum. So follow me. Now I told you in the beginning that this is the most violent species to human. Are you getting me now? The most violent species to human, and responsible for major severe malaria cause and death. So the major ones you see that is occurring in human, that people dies of malaria, in especially in some metropolitan area, in some area that are close to water, where the malaria eggs are breeded. Okay, now so they are much more violent there. And also the invaded blood cell of all ages, which we have talked about. They are highly parasitemic, which means they are high in the blood. So when they enter into the blood, they destroy every surrounding tissue they see. What is their relapse pattern? Two relapse do not occur here because hey, they don't form hypnozoid in the liver. When they enter, they are causing damage immediately. They don't even incubate themselves over a long period of time, maybe start causing issues with time. No. When they enter, they are destroying immediately. Recognition may occur after remission due to persistent blood stages. So even though you it goes, maybe you treat it over a long period of time, there are still some fragments that could still be surrounding in the blood that could still cause you infection. Are you getting me now? We can see induce some signs and symptoms for you, which means you could fight, you might treat it over a short period of time, it will go. But remember that most of them have damaged so many red blood cells. Maybe you could just treat the obvious ones that you could treat, but there are some that are affecting some red blood cells somewhere, or that are hiding themselves, not forming hypnozoid, but later they could just manifest themselves as signs. Are you getting me? Next one is the liver stage, or we'll call it the exoerythrocytic stage. Here what happens, first of all, the female Anopheles mosquito forms what we call a sporozoite in the salivary gland. So there's a sporozoite in the salivary gland here, which is stored and to be released to infect humans. So when the mosquito bites any individual, what happens now? You release the sporozoite into the blood. So when you release the sporozoite into the blood, the sporozoite will be channeled to the liver. Are you getting me now? So when it's channeled to the liver, it will infect the liver cells. So we call it exoerythrocytic stage, because naturally the primary destruction is to the red blood cell. So that is erythrocytic stage. But this one is exo. Are you getting me now? Which is in the liver. So it goes to the liver, destroy the liver. Are you getting me now? So when it incubates himself in the liver, what happens now? Now if it incubates itself in the liver, now that hepatic schizosuit will be formed. We call it the hepatic schizosuit. So when the sporozoite enters into the liver, it forms what we call an hepatic schizosuit. When it forms an hepatic schizosuit, what happens? It will be released as what we call the merozoite. Now, okay, now, so it's coming from the blood, entering into the liver. When it enters into the liver, it forms what we call an hepatic schizosuit. So when it forms an hepatic schizosuit, now what happens? It will rupture and will be released into the blood back as what? Merozoite. Don't forget, I come as sporozoite, I forms an hepatic schizosuit, then I rupture and release myself as what? Merozoite back into the blood. So coming from the blood to the liver, leaving from the liver back to the blood as a merozoite. So when it forms a merozoite, it enters into the blood, then it now affects all red blood cells of all ages. It could be young, it could be matured, it could be old. Are you getting me now? So when it's affecting all types of red blood cell, what happens? To give what? High parasitemia, which means it will be high in the blood, destroying the red blood cell. So now what is the characteristic feature here? One thing you have, there's what we call the molar cleft. The molar clefts are irregular course of pouches seen in the infected red blood cell. So if you want to see, there's what we call the molar cleft, and molar clefts are pouches around the red blood cell. Is how the signs you need to know that this is the Plasmodium falciparum, because it affects red blood cell, forming a molar cleft. Are you getting me? And how can you even know a molar cleft? You use what we call a Romsky stain or a Gimsa. So when you stain the red blood cell Gimsa or Romsky stain, what happens? You see a molar cleft there, you see some sign there, you see larger and fewer dots there, which I'm showing you here. Also, there will be squamosation of the red blood cell, which means the red blood cell will be damaged. Are you getting me now? So there will be breakdown of the red blood cell, and the infected red blood cell will be trapped in smaller blood vessels. Are you getting me now? Now when you start breaking down the red blood cell, called what we call hemolytic anemia, You break down the red blood cell, break them down, and all of them begin to trap in the arterioles or smaller blood vessels like the brain. I get it now, because there are smaller blood vessels there, which is the gyra artery, which is the sulci artery. Also in the renal artery, so it will be trapped there because they are smaller vessels. Also in the segmental arteries of the lungs, so it will be trapped there also. Now, one thing, there will be avoidance of splenic clearance. Why? Because the spleen will not be able to clear. I get it now. It will not clear the infection. That's it. It will not be able to clear the infection. Next, the spleen will not be able to clear the damaged and destroyed red blood cell, so it will pack in the spleen, causing splenomegaly. And now, due to the damage of this red blood cell, there will be severe disease and complication. Also, there is what we call the rosette formation too. Remember, the mural cleft, there will be squamosation and there will be rosette formation. So what is rosette formation? Now, the infected red blood cell will bind to the uninfected red blood cell, so they will call it cross infection, whereby the uninfected red blood cell will start affecting the infected red blood cell. I get him now. Now there will now be obstruction of what we call microcirculation, because I told you in squamosation, when the red blood cells are damaged, what happens? They'll start packing in the segmental arteries, they'll start packing in the small sulci arteries of the brain, they'll start packing in the arterioles, smaller arterioles of the various blood supply to every organ. Even the spleen cannot remove them. That's why it will be high in the spleen, causing a splenomegaly. Again, so also rosette formation here, that the infected red blood cell will be bind to the uninfected red blood cell, causing what? Cross infection. Again. So hope you understand it. We have introduced you, talked about the relapse pattern. We talked about the liver, the exoerythrophytic stage when it invade the red blood cell, and the characteristic what feature. Again. So what happens now? Inside the blood now, they form a ring stage. I guess now there will be a small ring that will be formed. Now the smallest ring stage now forms what we call a trophozoite, because now they were a merozoite first of all. I get it now, which you can see a molar cleft there, you can see a rhozoid formation. So what happens now? They now form a ring stage called a trophozoite. So a trophozoite will be formed. So remember, a sporozoite goes to the liver, forming what we call an hepatic schizocyte. I get it now, which transform and release as a merozoite. When it releases as a merozoite, what happens? It will now form what we call a small ring called what? A trophozoite. So a trophozoite will be formed here. After a trophozoite formed here, there will be multiple dictatable rings seen in the single RBC. So ring will be forming in the RBC. I get it now. But for molar cleft, there will be irregular course of bulges seen in the infected red blood cell. While in rosette formation, the uninfected red blood cell will the infected red blood cell will bind to the uninfected red blood cell. While a trophozoite will be formed in the sense that what happens? There will be small rings around the red blood cell there. Are you getting me now? The small rings will be formed around the red blood cell. Then when there's a small ring formed around the red blood cell, now what happens? Now about 10 days, what happens now? The merozoite now will now multiply, because the merozoite was released by the liver, forming a trophozoite. A trophozoite will now release and form a merozoite again. So those merozoites now will now start distributing themselves and what? Doing fertilization to give what? A male and a female what? Gametocyte. You get it now? So sporozoite, hepatic schizocyte, merozoite, a trophozoite where there will be ring. Now the merozoite can also now undergo fertilization to give what we call a male and female what? Gametocyte. So you can call it a microgametocyte and a female microgametocyte. Are you getting me? So now this male and female microgametocyte is what the mosquito will feed on and take into his body. You get it now? But he released sporozoite. And when he released sporozoite, what happens? When he's taken back, he'll be taken back either a male or female microgametocyte. So the question here is, why is Plasmodium falciparum very dangerous? It is very dangerous because it affects red blood cells of all ages, highly parasitemic, and also it causes desquamosation of red blood cell by breaking down red blood cell and causing obstruction in smaller vessels. Rhezoid formation will form. How will rhezoid formation form? Why? Because all the infected red blood cell will start binding to the uninfected red blood cell, and also there will be molar cleft, which means bulges of irregular course will be seen on the red blood cell. Also, there will be ring formation too in the the red blood cell forming a trophozoite also, and all this will cause systemic and massive manifestation. Are you getting me? So next we'll be talking about is the Plasmodium vivax. So what's the Plasmodium vivax here? I get it. So before you come here, you will have watched my video there on the Plasmodium falciparum. But in the Plasmodium vivax, it is the second most common cause of what human malaria after falciparum. Are you getting me now? It is less virulent. Always remember, it is less virulent than Plasmodium falciparum, but famous in what? Relapsing. So it relapse. Unlike falciparum, I told you falciparum do not relapse. It do not relapse. It just manifests itself. It do not relapse. So what happens now? Remember, it's a benign tertiary malaria and fever occurs lower than what 48 hours. Why the other one is a malignant tertiary malaria, which means you start seeing fever between 24-hour period. Are you getting me? So it's less severe and causes what significant morbidity. Are you getting me now? It invades young red blood cell, which means reticulocyte. Why the falciparum cause damage or the red blood cell of all ages? You get it now? So it produces low to moderate parasitemia. Why the falciparum produce high amount of parasitemia? But for this one now, when the salivary gland of the mosquito releases the sporozoite, it enters into the liver. So when it enters into the liver, instead of it forming what we call an hepatic schizosuit, now it doesn't form an hepatic schizosuit. Do you know what it does? It what hibernate. It hibernate and form what we call an hypnozoite. You get it now? It hibernate and form what we call an hypnozoite. So an hypnozoite is formed here, which means it doesn't just break down, form an hepatic schizosuit and release as a merozoite. So for vivax now, it stays first of all and form what we call an hypnozoite here. Get it now? So when it forms an hypnozoite, it stays for a long time. It could reach months, days, weeks, and years before it starts causing fever. So even though if it causes fever today, if you treat it, there are still some amount of the one that are present in the liver. That's why we have some anti-malaria medication that are channeled to what treat malaria vivax for those that are already inside the liver. You get it now? So now always look at it now. Remember, there must be formation on an hepatic formation of an hypnozoite first. So the hypnozoite that is formed here first will stay. So when the hypnozoite stays, what happens? It will cause relapsing fever over a long period of time. So it could cause recurrent infection all the time. So now when the hypnozoite is not transforming, it ruptures and forms what we call a merozoite. Are you getting now? It forms a merozoite. The merozoite now forms a ring shape, which you know called a trophozoite. The trophozoite now, are you getting now? The trophozoite ruptures and forms another merozoite again, just like the one we have in what falciparum. Are you getting now? Just like the one we have in falciparum. One thing you have to know that it invades young red blood cells. Are you getting now? Due to what? It has a duffel antigen. Are you getting now? So except from falciparum attacks all red blood cells of all ages, but this one attacks young red blood cell. Why? Because the vivax has what we call a duffel antigen, and the duffel antigen is positive to individuals that are susceptible to it. You get it now? Now it produces low parasitemia like Plasmodium falciparum. Are you getting now? The tertiary fever occurs in 48-hour period. Are you getting me now? Are you getting the red blood cell infected are large and shows what we call there's what we call a Skopnian's duct. So in vivax you see what we call a Skopnian duct, but when you go to falciparum you are seeing what we call a molar cleft or resort formation. But this one you are seeing a Skopnian's duct. Like I told you now, it forms a dominant form in the liver called the hypnozoite. Are you getting now? So the sporozoites do not just develop immediately. When it enters, it remains dominant in the liver, forming what? An hypnozoite. Are you getting now? So it's not affected by most anti-malaria drugs because when it stays, it is not forming anything. It is not affecting anybody. It's just there. Okay, now so it's there. Now relapse may occur in weeks. I told you relapse may occur in weeks, months, or even years. You get it now? But why? Because of the hypnozoite is just there, resting there. But when it wants to form, when it wants to cause disease, it just comes outside and causes disease. So that's why it sometimes do not give sign. It just happens. Are you getting now? But there are some drugs that are used to target the hypnozoite, like primaquine. Primaquine can be used to target, and tefenoquine too. Primaquine, tefenoquine, and proguanide. They are used to target the hypnozoite formation when you want to treat patients with exoerythrotic phase of malaria. Remember, Remember, when it is now released as merozoite, what happens? It forms a ring-shaped trophozoite. Then after it forms a ring-shaped trophozoite, it breaks out and forms another merozoite. So those merozoites now undergo fertilization to form a microgametocyte for male and a microgametocyte for female, which is fed by another red blood cells. Okay, now, so it's the same thing. Yeah, now it's the same thing. So the next one here is the malariae. Now, are you getting now? The malariae. What happens to the malariae here? So the malariae is the less common cause of malaria. We will call it the quotient malaria. Yeah, now it's the quotient malaria. But the unique stuff is that it forms a chronic, long-lasting infection, which can last for decades. Unlike falciparum, because now the infection is now. The vivax causes it stays and relapse over a long period of time. Why the malaria can cause a chronic long-lasting infection? I get it now. So one thing you have to know, I've taught you, it causes what we call a quotient malaria. Quotient malaria means that it can give a 72-hour period. It's mid because it doesn't just happen immediately. It can give you signs and symptoms which you'll be treating over a long period of time and maybe eventually kill the patient. It has low parasitemia. Why? Unlike falciparum, the parasitemia here is very low, which means when it happens, it can stay over a long period of time. Little by little, you treat, it goes. Are you getting? And it's usually seen in transfusion malaria, which means giving blood to another person. Same thing we know. Sporozoite enters into the liver, forms an hepatic schizosuit, leaves the blood and all the stuff which I've explained already. So the merozoite from the liver enters into the blood. It infects the red blood cell. Are you getting now? And remember, the red blood cell is always affect its old red blood cell here. So when it affects the old red blood cell, it forms a trophozoite. From trophozoite here, what happens? It splits open and release a merozoite. So those merozoites undergoes what we call some fertilization to give male and female what gametocytes. Are you getting me now? So, but one thing you have to know, just like falciparum, you have what we call the molar cleft. Just like vivax, what do we have? In vivax, we have what we call the Scoffner's duct. I get it. So you have a Scoffner's duct there. That's how you catch them. Then for the malaria, you have what we call a Cosbar granulus, what we call the Zimmer splitting. So in the Zimmer splitting, you have a Cosbar granulus here in malaria, and you get the malaria here is giving a fever of 72 hours. It invades old red blood cell. It forms a band. So that band you see on the trophozoite here is called a basket form of band. I get him now. So the characteristic feature of what you have to know here is that the trophozoite forms a basket form of band. Are you getting now? It forms a Cosbar granulus, which you call the Zimmer splitting, and it releases a schizosuit of about 6 to 12 merozoites. No hypnozoite formation here, unlike vivax. Are you getting now? And also they undergo fertilization to give you male and female what microgametocyte. In the ovale is just the same thing, give it the same formation as the vivax here. I get it, the same thing as the vivax. What do they do? Very simple. First of all, they cause what they call a mid-tertian malaria, which undergo like 48 hours, same with the vivax. Yeah, now so simple, same with the vivax. So what do they do? I get it, they affect young red blood cells, just like the vivax. Young red blood cells, they form an hypnozoid, which they say is in the liver. I get them now, and causing relapsing fever over a long period of time. So same thing with the vivax, the same thing. So I don't want to repeat it again because the Plasmodium ovale is the same thing with the vivax, which is rare, causing the least cause of malaria to humans. Okay, now so you don't really, so instead of having a vivax, you have an ovale, the same thing, because they are affecting young red blood cell. But when you have malaria, old red blood cell, a quotient malaria 72-hour period, right? Plasmodium falciparum occurs is a malignant tertiary malaria 24 hours, which occurs where the symptoms occurs immediately, the swelling red blood cell. So here there's relapsing, the same thing. Yeah, now so remember vivax, remember ovale. Yeah, now my a benign tertiary, but the only difference here is that for vivax yes is producing what a benign tertiary malaria, while this one produces a mid tertiary malaria, which is ovale. You get it now. So the next is the pathogenesis of malaria. So what's the pathogenesis of malaria? What what occurs when the merozoites are released into the blood. So what happens? There will be destruction of red blood cell. The parasited moth RBC ruptures and release merozoites. Always remember, so when they release merozoites, the non-parasitic red blood cells are also destroyed. Why? Because one, they destroy the red blood cell. So when they destroy the red blood cell, they release what we call hemoglobin. I get him now. Hemoglobin is released, which is released from the urine, causing what? Hemoglobinuria and black water fever. So there will be hemoglobinuria and black water fever, whereby also causing hemolytic anemia, which is the next one. So first of all, you have destruction of red blood cell. There will be destruction of red blood cell, which is the first one I always tell you. When they destroy red blood cell, the uninfected red blood cell will be damaged by the infected red blood cell. I get him now, causing hemoglobinuria and what? Black water fever. So there will be hemolytic anemia, because when you destroy red blood cell, what happens? There will be low amount of red blood cell that will be forming. Why? Because also they will invade the bone marrow to destroying the red blood cell. They go to the liver, destroy. So there will be hemolytic anemia. There will be reduced erythropoiesis in the bone marrow. So iron trapped in the hemosin cannot be reused. So you can remember, iron is supposed to be reused to form what? So iron is already trapped. Remember when I say the hemoglobin will be released in the urine, and in the hemoglobin there you have iron. So iron is trapped in the hemosin ring, and when iron is trapped as hemosin, what happens? You cannot reuse iron again. There will be severe anemia. And severe anemia, what? There will be reduction in red blood cell, the reduction in oxygen, which can damage structures. Splenomegaly. Now what happens in splenomegaly here? Remember, the spleen is enlarged due to removal of infected red blood cell. So remember, the spleen, what happens in the spleen? The cover cells come to what? Eat up all the damaged red blood cell, because the spleen is the graveyard of the RBC. So the spleen is the graveyard of the RBC, because the RBC there dies in the spleen. So now we have too many dead RBC there in the spleen. What happens? The spleen will be big. I get him now. The spleen will be what? So big. So when the spleen is big, what happens? Macrophages, cover cells will come there, causing what we call hyperactive or splenic macrophages. There will be hyperactive splenic macrophages because they are trying to break down the iron, the porphyrin. I get him now, and also the globin there. They are trying to break them down. I get him now. So this will cause persistent increase in chronic infection. Hepatomegaly. In hepatomegaly, what happens here? The spleen will be enlarged due to what? Accumulation of malaria pigment. So remember, there will be what? Hepatic schizocytes. There will be hepatic schizocyte, which is also a malaria pigment. So the liver will try to what? Detoxify it, but it will be hard to be detoxified. Okay, now. Also, there will be increase in phagocytic active of cover cells. The cover cell, which are tissue macrophages, will be released in order to neutralize those malaria pigments. But in doing that, due to increase in activity, it will make the liver to be big. The liver may appear dark due to hemosin. So the liver will be very, very dark. Why? Because its iron is trapped. I get him now, because there's destruction of RBC. Destruction of RBC releases hemoglobin, and those hemoglobin are stored as hemosin, so which will make the liver to be dark. Now when you damage red blood cells, they will be trapped in smaller blood vessels. I told you, in the sulci and gori arteries of the brain, in the renal arteries of the kidney, also in the segmental arteries of the kidney, and also the lungs. They'll be trapped in arterioles, and when they are trapped in arterioles, which means blood will not be able to move, there will be peripheral resistance, causing high blood pressure, causing a lot of strain. I get him now. So when the tissue is not being perfused due to blockage of red blood cell due to blockage of blood by this squamous red blood cell, it will cause tissue hypoxia, and tissue hypoxia might cause necrosis. Margination. Now what is happening in margination? So the parasitized RBC will adhere to the endometrial lining. Are you getting? So when they adhere to the endothelial lining, what happens? Non-infected RBC will flow at the center. Are you getting now? So as they are marginating themselves in the endothelium, what happens? They will be reducing space for good RBC to flow through, while increasing peripheral resistance. Okay, now so remember, so in sequestration of the RBC, what happens? They'll be accumulating in peripheral blood vessels. But when they accumulate there, they marginate themselves in the endometrial and the endothelial lining. What happens? Reducing space for normal RBC to pass. Are you getting it? This will cause what we call microvascular what obstruction. Next one, there will be leukopenia. Why will there be leukopenia? Because there will be increase in number of circulating monocytes. And when there's increase in circulating monocytes, what will the body do? The body will try to reduce the release of what? White blood cells. Because some of the white blood cells are even being damaged by the malaria parasite. So how does it happen? Now, naturally, in the fever mechanism here, first of all, there will be a rupturing of RBC. When the malaria parasite, which is a merozoite, bind to the RBC, it will break down the RBC. Are you getting me? So the breakdown of the RBC, are you getting me now, will form a trophozoite. The trophozoite will also now ruptures again and give us a merozoite now. So there will be release of merozoite and the what parasite what pigment. So merozoite from the liver forms a trophozoite. A trophozoite ruptures and forms another merozoite. So when merozoite do is that merozoite will invite what we call macrophages, monocyte, and other white blood cells to the site. So at that particular point, as they are coming now to neutralize, they release pro-inflammatory cytokines, which are pyogene cytokines. So why do I call them pyogene cytokines? Because why? They are great stimulator of what? Fever. So immediately those pro-inflammatory cytokines are released into the blood. They go to the hypothalamus and change the hypothalamic set point. What happens? Stimulating the anterior part of the hypothalamus to increase what? The body's temperature, causing what? Fever. Are you getting that? So there will be fever, chills, and what? Sweating. You get it now? So remember, there's a merozoite from the liver forming a trophozoite. Trophozoite ruptures, forms a merozoite. Merozoite release chemotaxin, causing what we call immunity, whereby white blood cells come to the site. When they come to the site, what happens? They release pro-inflammatory cytokines, which are pyrogenes what? Cytokines, which binds to the what? Hypothalamus to increase the hypothalamic set points, causing what? Fever, chills, and sweating. So what are the complications of malaria now? So when there's malaria, what happens? Now, first of all, in a large part of it, now, apart from all those one we have said, the highest form it can cause one is cerebral malaria. Are you getting now? The complication, especially when we say complication, we're talking about Plasmodium falciparum. So there will be cerebral malaria, so which means it can enter into the brain. Are you getting now? It can enter into the brain. So remember, I told you in sequestration now of red blood cell. If there's sequestration, which means the red blood cells will be broken down to smaller red blood cells, go to this smaller blood vessel like this sulci arteries. Remember, in the brain now, what happens? We have what we call the middle cerebral artery, which gives a sulci arteries. These are small arteries present in the sulcus of the brain. So if it goes there, what happens? It will block the red blood cell there, preventing blood from moving to be supplied to the brain. And when blood is not being supplied to the brain, it can cause what we call seizures, it can cause coma, it can cause impaired consciousness. So in cerebral malaria, it is much more prominent in children. Why? Because there is sequestration of red blood cell, blocking blood flow to some particular part of the brain. Pulmonary edema. Are you getting that? In pulmonary edema, what happens? There could be what? Blockage. There could be sequestration of the segmental arteries, blocking blood flow to what? Different part of the lungs. Remember, in the bronchopulmonary segment, the lungs can be subdivided into different what? Lobes and segments. Are you getting me? So if they are divided into different lobes and segments, which means as far as there's sequestration, as far as some small damaged red blood cell is blocking blood flow to so many parts of the lungs, which means what happens? There will be blockage of blood flow to that side, which will cause what? Pulmonary what? Edema. Why? Because due to inflammation, what happens? There will be vasodilation of the blood vessel, causing fluid build up inside the lungs. Remember, in acute what? Inflammation. In acute inflammation, what happens? There's what? Edema. Why? Because they've blood vessel capillary permeability, and those capillary permeability allow fluid to leak from the blood into the tissues. And when the fluid builds up into the tissue, what happens? The lungs will start producing a lot of mucus and liquid. And when you start producing a lot of mucus and liquid, even though you take in air, there will be increase in blood air barrier, which means the surface tension of the lung will reduce. And when the surface tension of the lung reduces, what happens? Air will not be able to reperfuse the blood, which means you'll be circulating what? Bad blood. So there will be pulmonary edema, and pulmonary edema causes rapid breathlessness. Are you getting me now? So there'll be hypoxia, there'll be dyspnea, you will not be able to breathe. Are you getting me now? And there'll be difficulty in carrying on your daily activity. Why? Also there'll be chest crepitus. Chest crepitations will be there, because as you breathe in, what happens? There will be sound that will be produced. Next is that there will be Algid Malaria, because there will be severe hypothermia, whereby the body temperature will drop. Are you getting me now? Body temperature will drop at first, because before you start, there will be fever, there will be chills. Are you getting me now? There will be fever first, but before fever, there will be Algid Malaria, whereby there will be hypothermia, whereby the body's temperature will drop and the patient will start feeling cold before he feels hot. Next is that there'll be black water fever. In black water fever, what happens? Remember, the red blood cells being broken down. And as the red blood cells being broken down, what happens? It is releasing hemoglobin. And hemoglobin is being passed out to the kidney as what urine. So which will give us that Coca-Cola color. So the Coca-Cola color you see. Why? Because there's intravascular hemolysis of red blood cell, passing all the red blood cell as what urine. So you'll be seeing there'll be hematuria, which means your urine will be very, very red. But in this case now, due to black water fever and due to your body is releasing the hemoglobin, there will be what hemoglobinuria, which means it will not be light red, it will be very, very dark. So this will lead to acute kidney injury and shock. Next will be hypoglycemia. Remember, the parasite will start taking up your glucose. Are you getting me now? So because in the stored glucose you have taken as glycogen, the parasite will eat up the glucose, and when they eat up the glucose, what happens? Immediately your glucose level drops, so you'll be hypoglycemic. So hypoglycemic will occur. Why? Because the bacteria and your even white blood cell, due to the activities of immunity, both the bacteria and also your white blood cell will use up your glucose, causing hypoglycemia. And instead of your body to produce another glucose, what happens? There will be impaired gluconeogenesis. So if there's impaired gluconeogenesis, you'll be there will be outright hypoglycemia. So what you see? You will be sweating, there will be weakness, there will be confusion, and there will be seizures. Are you getting that? Because your glucose level will drop. So there will be renal failure. Why? Because you are removing all your hemoglobin from your urine, and as you are removing it, also water is going, which is causing dehydration, and as it's doing, what happens? There will be vasodilation of the blood vessel. Why? Because there's fever. Are you getting that? So when there's vasodilation, there will be drop in blood pressure, causing hypotension. And as there's drop in blood pressure, what happens? There will be acute tubular necrosis, because the renal tubule will also be damaged, because there's no blood supply to them due to what we call the sequestration of the red blood cell. Because why? There's blood is not being supplied to them. Why? Because they are being blocked. So there will be acute tubular necrosis. And if there's acute tubular necrosis, what will happen? There will be reduction in urine output, causing acute kidney injury. Your electrolyte, there will be electrolyte imbalance, and also uremia. Are you getting me? Uremia. So always remember that. Always remember that. One, because also, even though there's acute kidney injury, not that you are releasing the urine output is low, but even though you release the urine output, it is highly containing hemoglobin. Are you getting that? Instead, all your liquid will be entering your tissue, causing edema. So the edema is the first sign of renal failure. There will be edema. After there's edema, there will be hemoglobinuria, which is black water fever. Are you getting me? There will also be hypotension. Are you getting me now? Due to increase in RAS mechanism and also vasodilation of the blood vessel. There will be azotemia, because there will be increase in creatinine and BUN. Yeah, now. So many things will be occurring. Are you getting me now? There are many things. So other systemic complications, there will be jaundice. So jaundice, why? Because hey, as you are increasing red blood cell destruction, as you increase red blood cell destruction, what happens? The red blood cell, remember, there will be increase in porphyria. And for you to have porphyria, what happens? Bilirubin has to break down porphyria. So since the high bilirubin action, due to this high increase in red blood cell, high increase in porphyria, bilirubin level will be high, which will cause jaundice. So jaundice is the first sign of liver failure. There will be bleeding tendency. Why? Because your body, there will be reduction in platelet formation, cause thrombocytopenia. There will be reduction in platelet formation. There will be coagulopathy, reduction in platelet formation, which causes chronic bleeding. The patient can go into shock. Why? You already have anemia. Are you getting anemia? Dehydration, hypotension, which is a classic sign of what we call hypovolemic shock. But first of all, you can have septic shock because of the infection, and hypovolemic shock due to the decrease in fluid in the blood. Hypersplenism is another case. Now in hypersplenism, what happens? This leads to what we call pancytopenia. What is pancytopenia? Why? One, there's anemia, there's leukopenia, and there's thrombocytopenia. We call them pancytopenia. And now, due to this decrease in everybody, due to anemia, the malaria parasite is destroying the red blood cell. Also, the white blood cell is being reduced. Why? Because they have exhausted the white blood cell production. And also, if the white blood cell production, the hematopoietic stem cell is already infected, decreasing the three of them, causing pancytopenia. Okay. Next one is diagnosis of malaria. How can you diagnose it? The gold standard here is doing microscopy locally. So we have a thick blood film and a thin blood film. Now a thick blood film is more sensitive and can be used to detect large amount of parasite. So when you take the parasite, now you put it on a petri dish, what happens? Or you put it on a slide, if you see how thick it is and how widespread it is, you know that it contains parasite. So this one is a gold standard just to check the amount of malaria that is in there. Finish. So the parasite density means that the amount of parasite that is present there causing it to be widespread. So this is just to check the amount of parasite in the blood. So it's a good standard, but it's not a differential. So you get it now. So it's used to check the wide amount, because in a thin film there's less parasite there, but you don't know whether it's malaria yet. Yeah, now you just check the amount of parasite there by putting it in a slide, and when you put it in a slide to be widespread, this confirms that there's a parasite using a thick blood film and a thin blood film microscopically. A rapid diagnostic test. Now in rapid diagnostic test, you use it to confirm the parasitic antigen, which is the malaria falciparum releases antigen. So when it releases antigen, I get it now, what happens? You detect it with a rapid diagnostic test, RDT. In RDT, what happens? When you take the malaria parasite and put it into an RDT machine, what happens? It detects the malaria antigen in 15 to 20 minutes. I get it now. So it is used for an area where there's low microscopic availability. That's what it's used. You get it now. In Plasmodium falciparum, what will you be seeing? You'll be seeing an HRP2 and an antigen there. If it's in falciparum, while even seeing vivax, what you see, you'll be seeing what we call an aldolase, or you see a P lactate dehydrogenase there. Okay. So an RDT is less sensitive than microscopy, because in microscopy here, what happens? You are seeing a high amount of parasite in the blood. But in rapid diagnostic test, you are just using to confirm that there is a parasitic antigen in the blood. Now you are using a PCR. A PCR method is highly sensitive. I get it now. You cannot use it to detect parasitemia in the blood, but you can use it to detect the pathogenic DNA. So you can use it to catch the DNA of the parasite in the blood by taking it and putting it into the equipment. But the only thing that is highly expensive is usually very useful. Why? Because it detects the one that is there. It can be Plasmodium, vivax, it can be any of them. But in microscopy, you are just checking the amount of parasite that is located there. So remember, microscopy, rapid diagnostic test, and PCR. So when you want to check the laboratory findings, what are you seeing? You'll be seeing pancytopenia. What's pancytopenia? You'll be seeing reduction in red blood cell, which is hemoglobin, reduction in white blood cell, reduction in platelet, increase in bilirubin causing jaundice, and also increase in BUN and creatinine. I get it now. Which you call azotemia. You know. So you see the parasite level. If you check it in a microscopy test, what do you see? If the parasite is less than 1000, I get it now, which is a Scopnice node. If you see a Scopnice, if you see the parasite less than 1000 in the slide, what happens? Which means it's low parasitemia. If you see between 1000 to 10,000, medium, but you see above 10,000, show you that it's highly parasitemic. Now, how do you collect the sample? When you collect the sample, what happens from the blood? Usually from venous blood, and you store it in a degree about 4 degrees Celsius. So when you store it in 4 degrees Celsius before you start to test it, you get it now. So how can you prevent malaria? So we want to prevent and control malaria now. First of all, vector control. You control the Anopheles mosquito. So in a high prevalence area, how do you call it? You target the breed of mosquito that is being affected there. So you can control the female Anopheles mosquito. If you eliminate the female Anopheles mosquito, which means there is no malaria, you can use insecticide nets by covering yourself with insecticide-treated nets. So when you cover yourself with insecticide-treated nets, what happens? Malaria parasites will not be able to enter. So you have to fumigate the area. So how can you fumigate the area? By using a spraying insecticide in the area. So when you spray insecticide in the area, what happens? It will kill malaria breed, all those malaria eggs that are stored that can be taken from the body. It can kill it. So first one, you control the vector, which is the female Anopheles mosquito. 2, you use an insecticide-treated net. 3, you do fumigation of that area by spraying insecticide there. Also your sanitation, drain stagnant water because they breed malaria. Now you have to remove all waste product around that area, sanitize there, spray different things that can desanitize everything. You cut bushes and remove tall grasses. You get it now? All these things helps to what? Reduce the breeding of what? Malaria. Chemoprophylaxis too, you can use drugs, anti-malaria drugs. I get it now. We have drugs for travelers. I get it now. We have drugs for pregnant women. I get it now. We have drugs that can treat the malaria before it even starts. So you take chemoprophylaxis, taking the drugs before the malaria symptoms come. So early diagnosis is very, very important, because when you start seeing the signs, or before you see the signs, you take an anti-malaria medication. And the most important one that is in use is what we call the ACT, which is Artemisinin-Based combination therapy. Artemisinin-based combination therapy is artemisinin, different artemisinin. You have artemether, artesunate, I get them, and dihydroartemisinin. They are used in combination of other drugs too. Okay, now you need health education, so you tell them how to prevent malaria by what? Doing some measures that are very, very important. The use of nets, clean disposed water, removing disposed water, clean dustbin around the area, sanitizing that place, washing your hands, keep your place neat. Health education is needed. Community participation too is also needed. Why? Because you have to do a massive campaign to tell people on how to control malaria. Yeah, so I hope it all made sense and you have understood everything I talked about in malaria. So if you are new to my channel, make sure to subscribe, turn on your post notification button, so at any time I drop any video, you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make that video solely for you. Okay, now so we talked about malaria here. So in my next video, in other videos, you see the anti-malaria medication, the drugs we use to treat malaria. Because remember, we have the falciparum, we have the vivax, we have malariae, and we have the ovale, and all of them have different drugs used to target them. But the most virulent is falciparum, and I've given you how it works, the characteristic feature, and what all of them have. So I'll be seeing my next video, because I'll be doing the black water fever in the next video, which is hemagglutinuria. After hemagglutinuria, I do toxoplasmosis. After toxoplasmosis, I do leishmaniasis. Like that. The video is just on parasitology, so you follow me to the end. I'll see you in my next video. Bye bye.